Hello everyone, a very warm welcome to today's episode of Pediatrics with Dr. Kazmi, where we explore critical topics in child health and pediatric emergency medicine. I'm your host, Rosina, and I'm absolutely delighted to have with me Dr. Syed Kazmi, a consultant in pediatric emergency medicine. Today we'll be talking about one of the most urgent and high-stakes situations in pediatrics, and that is status epilepticus. Dr. Kazmi, thank you so much for joining us.
Thank you for having me, Rosina. It's a pleasure to be here. And I'm really glad that we are discussing this because status epilepticus is one of the most important pediatric emergencies that nations need to recognize and manage promptly.
Let's start right at the beginning. For listeners who may not be doctors, could you explain exactly what status epilepticus is and why it's such a big concern in pediatrics?
Absolutely. Traditionally, status epilepticus was defined once upon a time as a seizure lasting 30 minutes or longer. But over the years, we have learned that waiting that long is far too dangerous. Now, today, the accepted definition is 5 minutes of continuous seizure activity or recurrent seizures without any recovery in between. And the reason is simple. The longer a seizure goes on, the more resistant it becomes to treatment and the greater the risk of brain damage. Now, coming to the second part of your question, that why is this such a big issue in pediatrics? The reason that it is a big issue in pediatrics is because in children, status epilepticus is actually the most common neurological emergency. Now, about 8% of children will have an unprovoked seizure by the age 15 years, and around 1 to 16% of these children can progress to status epilepticus. And the highest risk is in children less than 2 years of age. And in terms of outcomes, mortality is around 2.7 to 8%, while 10 to 20% of survivors may have long-term neurological deficits. So it's truly a time-critical emergency.
That's striking. So you said 5 minutes is the critical cutoff. Can you explain why early and aggressive treatment is so important in all this?
Yes, and this is really the key message here. Now, once a seizure passes 5 minutes, the chances that it will stop on its own decreases dramatically. The brain becomes more seizure prone and becomes less responsive to drugs. That's why early intervention is the single most important factor for better outcomes. Now, if you give benzodiazepine, which are the first line drugs, within 10 minutes of seizure activity, then they are up to 20 times more effective as compared to if you delay the treatment. So the golden rule is don't wait and treat promptly.
So let's get into the treatment. What's the first line approach when a child presents with ongoing seizure activity?
The first line treatment worldwide is benzodiazepines. Now, there are 3 choices here depending on the situation. Now, that could be IV lorazepam, that could be buccal or intranasal midazolam, or sometimes rectal diazepam, depending on what's available and how quickly it can be given. So, in my opinion, the stepwise approach is number 1, at 5 minutes, you give the first benzodiazepine, whether it's lorazepam, midazolam, or rectal diazepam. If you are giving lorazepam, then the dose is 0.1 milligram per kilogram of body weight to a maximum of 4 milligram in total. If you are using buccal midazolam, then it's 0.3 milligram per kilogram body weight. And if you are using rectal diazepam, then the dose is 0.5 milligram per kilogram of body weight, and these are all APLS doses. Then coming to number 2, you have to wait 5 to 10 minutes after the first dose of benzodiazepine. If the seizure hasn't stopped, then you have to give a second dose. But we always avoid a third dose. Why? Because that significantly increases the risk of respiratory depression and the need for intensive care. And a very practical clinical pearl here is that the second dose of benzodiazepine should only be given by someone trained and ready to manage airway issues, like somebody who's APLS certified, because respiratory depression is the main side effect.
Now, suppose the seizure continues despite 2 benzodiazepines. Then what comes next?
That's where the second line therapy comes in. Now, traditionally, we have used phenytoin or phenobarbital in the past. But more recently, research has shown that levetiracetam, which is also known as Keppra, is just as effective as phenytoin with fewer side effects and a much simpler administration. Some of the trials like EcLiPSE, ConSEPT, and ESSET, these are all trials, they have demonstrated that there is no clear superiority between phenytoin and levetiracetam. But levetiracetam is easier to give and is safer in many ways. It is given in a dose of 40 milligrams per kilogram body weight. In practice, if the second line drug doesn't work, we sometimes consider a second line option before moving on to intubation. That means giving the second dose of the second line medication, and especially in settings with limited resources. In that particular case, if you are going for a second line medication, if you have already used Keppra, then you can use phenytoin in a dose of 20 milligrams per kilogram body weight, given over 20 minutes, but the dose maxes out at 2 grams.
And what if second-line therapy still doesn't work?
Well, then we are moving into the territory of what we call as refractory status epilepticus. At this stage, the child would likely need what we call as RSI, which means rapid sequence induction and intubation, often with an anesthetic agent like thiopento. This is where intensive care comes in. It's a major decision because RSI carries risk, but if the seizure is ongoing, despite optimal drug therapy, securing the airway and controlling the seizure is the only safe path forward.
That covers the drug ladder beautifully, but you also emphasize in your teaching that we can't lose sight of the basics. Could you talk us through the ABCDE approach in status epilepticus?
Yes, because we focus on stopping the seizure, we must not forget the child as a whole. The ABCDE approach of emergency medicine keeps us systematic. So first is airway. So remember, in that particular case, you have to clear the vomit or any secretions from the mouth. You have to position the child and consider an airway adjunct like an oropharyngeal or a nasopharyngeal airway. The second is your breathing. You have to assess the effort of respiration, apply oxygen in a dose of 15 liters per minute via non-rebreathable mask, and support ventilation if needed. Third is your circulation. So you have to secure an intravenous or intraosseous access as soon as possible. Check the perfusion and take bloods. Fourth is your disability. So you have to do a quick neuroassessment like pupillary size and reaction to light. And remember, always check glucose. We always say in emergency medicine, don't ever forget glucose. And finally, your E4 exposure. You have to do a full exam for rashes, any signs of trauma, any signs of infection or injury. So this structured approach helps us not to miss critical reversible causes.
Speaking of causes, what are some of the most common reasons that can make children go into status epilepticus?
Now, the most common cause in young children is febrile seizures. For others, it may be known epilepsy with some breakthrough seizures, or sometimes CNS infections like meningitis and encephalitis. Sometimes metabolic problems like hypoglycemia or hyponatremia, they also become important if a child is having refractory seizures. As well, sometimes we have to think about trauma where intracranial hemorrhage can cause seizures, or sometimes it might be a sequelae of certain toxins. And in pediatric practice, we must always consider a non-accidental injury if the story is not adding up. So a good history from caregivers and a good history from paramedics is invaluable to guide management in status epilepticus.
Let's make this concrete with the case. Could you share an example from your practice or teaching?
Of course, one illustrative case is that of a 1-year-old child who presented to us with continuous seizures a couple of weeks back. Now, in his pre-hospital course, the paramedics had already given him 2 doses of rectal benzodiazepine and route, but the seizures continued. By the time of arrival in emergency department, he was still having seizures for almost 15 minutes non-stop. So what we did in the ED, we used the ABCD approach, as I told you earlier. We got an IV access and we checked glucose. The glucose was normal. We collected the bloods. This child was febrile at 39 degrees Celsius. So infection was there on our radar. So as a second line medication, we gave him phenytoin, but by 70 minutes of the start of the seizure was still ongoing and he was not responding. So the decision point at that stage is that we escalated to RSI and intubation. Now, when we went for the intubation, we gave him the general anesthetic that stopped the seizure. We also did a CT brain in that case, which showed some changes consistent with encephalitis. So in that case, we treated him with the intravenous acyclovir and hypertonic saline, which actually helped him. Later on, he became better. So this case really highlights the importance of acting systematically, treating early, and knowing when to escalate.
It's fascinating how much research has shaped practice in the last few years. Could you share some of the latest developments?
Yes, several major trials in 2019, like the EcLiPSE and ConSEPT trials, they showed that levetiracetam or Keppra is as effective as phenytoin for second-line therapy, and that it is safer in some respects. Then the ESSET trial in United States of America, it reinforced all this evidence. So another key learning point is avoiding benzodiazepine stacking, because giving 3 or more doses increases the risk significantly without any added benefit. And moreover, I would say that the guidelines are evolving. I mean, in many regions, levetiracetam is now incorporated into the protocols, and this is reflecting this new evidence.
Dr. Kazmi, before we wrap up, what would you say are the 3 key take-home messages for our listeners?
So I would summarize it as follows. Number 1 is that treat early. So seizures over 5 minutes need prompt benzodiazepine therapy, period. Number 2, follow the stepwise ladder. Follow the status epilepticus algorithm. So that is 2 doses of benzodiazepines, then the second line medication like Keppra, and then escalate if needed. And number 3 is that think holistically. Use the ABCDE approach, investigate the causes, and always remember glucose. Now, if we do those 3 things, we give children the best chance at good outcomes.
Brilliantly put. Thank you, Dr. Kazmi, for sharing your expertise and experience.
Thank you, Rosina. It's been a pleasure.
This has been an invaluable discussion on pediatric status epilepticus, an emergency where every minute truly counts. And to our listeners, thank you for joining us. If you found this helpful, don't forget to share the episode with colleagues and subscribe for more pediatric insights. If you have any questions, queries, or comments, kindly put them down in the comment section. Until next time, stay informed and stay prepared.